Very good morning to everyone and a warm welcome to Isokamosh-Con 2025. We shall begin with our first session for today on hepatobiliary malignancies. I invite the chairpersons for today's first session onto the dais. Dr. Ganesh MK, Professor and HOD, Department of Surgical Gastroenterology, Father Muller Medical College, Mangalore. Dr. Manish Bhandare, Professor and Unit Head, HPB and Upper GI Surgery, ACTREC TMC Mumbai. Dr. Jairam Shenoy, Professor, Department of Surgery, KMC Mangalore. Dr. Harish Rao, Professor, Department of General Surgery, KMC Mangalore. I now invite Dr. Ashwin Polnaya to give us a talk on the role of interventional liver-directed therapies in HCC. Dr. Ashwin Polnaya is an interventional radiologist working at AJ Hospital and Research Center, Mangalore. Over to you, sir.
A very good morning. At the outset, I would like to thank the organizing committee to give me an opportunity to discuss about the interventional radiology directed therapies in managing HCC case. As we all know, that liver cancer is the 6th most common cancer, but still it accounts for nearly, it's the 3rd most common cause of cancer-related deaths because of the poor prognosis associated with these cancers. The complexity that we often face is that HCC care does not just involve managing the cancer alone, but the underlying cirrhosis as well. Treatment landscapes for HCC is ever evolving with multiple modalities involved in optimum patient care and often requires a multidisciplinary approach with individualization and customization of the treatment. Why is this? Because of the multiple patient factors involved, liver status, whether the patient is cirrhotic or non-cirrhotic, underlying liver function, the size, location, extent of cancer and comorbidities, and functional status of the patient as well as the patient preferences. Surgical resection remains a gold standard treatment in the management of HCCs. And liver transplant is probably gives the best curative option for managing HCC as well as the underlying cirrhosis. However, at presentation, most of these patients are not surgical candidates, with less than 20% of the patients with HCCs are fit to undergo a curative surgical option. While more than 30% of the patients are often at advanced stage at presentation, where no curative option can be provided. Hence, there is a need for liver-directed local regional oncological treatment, both with the therapeutic role as well as bridge and to downstage these patients for definitive surgical management. This is where the local regional treatment for HCC come into play, which may be in the form of either transarterial therapies or the ablative therapies. There is a whole spectrum involved which we have in our armamentarium to deliver these ablative therapies as well as transarterial therapies. It will be beyond the scope of my talk to go into individual of these things. I will give you an overview so that we get an idea about how to proceed. Like I said, HCC management often requires a multidisciplinary team approach involving all the main 4 pillars as well as the palliative care management. Resection still remains, as far as the broad guidelines is concerned, if the liver remnant is good. Transplantation under the Milan criteria with nodules less than 3 in number. And thermal ablation especially is helpful if lesions are less than 3 in number and lesion size is less than 3 centimeter to get a good curative option. Now, chemoembolization remains the mainstay in the treatment of intermediate HCCs, where resection and ablative treatments are contraindicated and can be used as a bridge for transplantation. Now, various regions often offer different guidelines, protocols. We often use the ESAL as well as the BCLC criteria and the guidelines to deliver the treatment from the local regional therapy point of view. Barcelona Clinic Liver Cancer, that's the BCLC, it helps in classifying the HCC patient and guides treatment recommendation based on the tumor burden, liver function and performance status. This BCLC staging has undergone serial modifications with The recent ones incorporating more aggressive and emphasis on the local curative treatment options. The modified BCLC staging gives more emphasis for in early detection of these cancers so that these curative options can be offered in these patients. There is this slide, though it gives what is the likelihood, the level of evidence and the treatment recommended for these HCC cases in different stages under BCLC. These keeps changing over the years with recommendations and evidence showing one better over the other. Coming to the BCLC 0, the stage 0, here it is a very early stage HCC where radiofrequency ablation has shown a good results with curative option, especially in lesions which are located in favorable location and can be offered as a first-line therapy even in surgically fit patients. Microwave ablation has shown good local control and survival. However, various studies have shown that the different ablative treatments have not shown any statistically significant difference in the overall survival between them. In BCLC stage 0, surgery is no longer the only first-line treatment available, and ablation often provides an excellent result for lesions less than 2 centimeters, and various case control and modeling studies have shown that ablation is found to be non-inferior and more cost-effective in managing very early HCCs in comparison with surgical and the early stage HCC, that's the BCLC stage A. Here there is HCC which are related with any obvious vascular invasions are contraindicated for surgical resections. In those patients, the primary role tends to be to offer a surgical option as well as the liver transplant in the main line of treatment for these patients. And neoadjuvant therapy or adjunctive therapies, though can be used in keeping these patients within the stage so that a more curative option can be offered at a later date. Liver transplant, like I said, is the main line treatment. However, patients with vascular invasion or with extrahepatic disease are absolute contraindication for a liver transplant. Now, in a pre-planned neoadjuvant setting, local regional therapies are recommended to reduce the risk of pre-liver transplant dropouts as well as lower the liver transplant recurrence, which is particularly true if we see patients who respond very well to liver-directed therapies like TACE or ablative treatments. And thermal ablations with radiofrequency is the standard of care in patients who are not suitable for surgical resection or where major surgical resection or segmentectomy may be required to treat these lesions because of its location. TACE remains the cornerstone in the management of BCLC stage P, and it should be carried out in a selective or a super-selective manner as far as possible. There is no statistically significant difference between the drug-eluting bed TACE or the conventional TACE, and either of them can be utilized. TACE should be avoided in patients with decompensated liver disease or advanced liver and kidney dysfunction or patients who are having extrahepatic spread of disease, as it cannot deal with these extrahepatic disease. TACE has shown to be safe though it was initially considered as a contraindication in portal vein tumor thrombosis cases. When done superselective in select patients, it can be done safely with better local response rates. BCLC stage, that is more advanced with vascular invasion, from radiological or intervention radiology point of view, TARE can be offered, and it has been evaluated in in seeing these patients as a bridge for liver transplant, or in patients in BCLC-B as well as in C, to compare them with the sorafenib. Current data shows that the good results have been shown with the TARE in local disease control and in downstaging and down in these patients for any definitive surgical resections. Tumor ablation. Basically, in tumor ablation, we apply a needle or an electrode, generate local physical energy in the form of either heat or cold to cause tumoricidal effects. Chemical ablations may be done using absolute alcohol or glacial acetic acids. But to achieve a good local response rates, we need to target the lesions which are early in its occurrence or size which are less than 3 centimeters to get a good curative margin. Among the tumor ablation, we have various, depending on the energy used to generate heat, they may be in the form of RFA, microwave or laser ablation, or even high intensity ultrasounds, commonly referred to as HIFU, or cold energy can be used using cryoablations. However, over the various studies, no thermal ablation strategy has been demonstrated to be significantly superior to each other. With respect to ablation, inoperability refers to lesions which are more than 3 centimeter size, more than 3 lesions, or unfavorable locations like dome or near major vessels or biliary ducts, and extrahepatic disease and vascular invasion. With respect to transarterial therapy, the main rationale is that the tumors HCC are predominantly supplied by the hepatic arteries, so that we can deliver the chemoembolic agent through the hepatic artery, through the tumor feeders into the tumor bed to get a good localized effects. There is both combination of ischemia as well as the chemotherapeutic drug effects. Now, this may be done as either a bland embolization where only ischemic effect is shown to give the tumoricidal effect, or using chemoinfusion, or using chemoembolization where a combination of chemoembolic agents give rise to the chemoembolic effect or the tumoricidal effect. Maybe in the form of conventional TACE where we combine it, the chemotherapeutic drug with lipidol, or it can be loaded into special microspheres which are referred to as drug-eluting beads. In transarterial therapy, unlike the procedure is almost in similar lines, but instead of chemotherapy, we infuse the radioisotope Y90 through that. So in chemoembolic, there is more of ischemia as well as chemoembolic effect. And in radioembolization, the spheres are smaller, which are delivered and gets lodged in the tumor and brings about local tumoricidal effect because of the radiation. TACE versus bland embolization. Though initial studies showed that the TACE is better, over the years and various studies have recommended that chemoembolization as well as the bland embolization have shown similar adverse events as well as the overall survival effect. And it can be considered as an alternative to conventional TACE or drug-eluting bead TACE. Studies have shown that conventional TACE and DEB TACE are equivalent and can be used either way. With respect to TACE versus TARE, it can be used. It has shown that TARE has shown a favorable response in patients undergoing the procedure as a bridge to liver transplant or to downstage to liver transplant, or as a bridge to liver resection and downstage the liver resection. TACE studies have shown that it is can be done safely even in patients with superselective nature, in patients with portal vein thrombosis. Often we use clinically a combination of various modalities that we have in our intervention radiology armamentarium, like combination of TACE with RFA, TACE with and TARE combination, TACE with portal vein embolization as a bridge to surgery, or combining it with any form of systemic therapy or SBRT. Quickly showing few cases here, the HCC focus was directly ablated without offering any chemoembolization in this patient. Here there was a larger lesion. Initial chemoembolization was done, and the lipidol-laden lesion was then subjected for drug-eluting bead test. Here we can see there is complete response after a single session of drug-eluting bead test. Often a combination, when the lesions are large, they can be initially a chemoembolization is done, which helps in one localizing the lesion as well as reducing the size, and then following it up with the RFA, ablative treatment. And evidence in literature has shown that combining TACE with RFA often gives a better local disease control compared to TACE alone or RFA alone. This is another case where a large lesion, more than almost 15 centimeter, was subjected for a sequential depth TACE, and this patient on follow-up, the lesion has significantly regressed over 9 months down the line, and then a small focus of HCC focus recurrence was seen. This was because the lesion had regressed so much that we could proceed with the ablative treatment, and this patient had a good clinical outcome. Here where vascular invasion is there, we can see the good localization of the radioisotope within the tumor thrombus, and we can see post follow-up there is complete response. To summarize, HCC is a multidisciplinary and multimodality approach. Ablative treatment is effective alternative to surgical resection for BCLC stage A and stage 0. TACE is the standard of care in patients with BCLC stage B and should be carried out in selective manner. Depth TACE or conventional TACE does not make a difference, as both are considered to be equivalent. TARE again is effective, and often a combination therapy is often required, and treatment strategy needs to be customized to individual cases based on their clinical condition. Thank you.
Thank you, sir. Thank you, sir. The session is open for discussion, but due to time constraints.
Very nice broad overview of all the therapies that are available. Any question from the audience? Otherwise, I have a question. In your slides, you mentioned that TACE or TARE or transarterial therapies can be used in combination with other modalities as well. So, which are the scenarios specific where you will use TACE as well as a TARE in the combination, and where you will use TACE along with SBRT, because SBRT is also now a very upcoming evidence-wise good therapy for HCCs, especially in portal venous thrombosis.
The combination of TACE and TARE is in one scenario where we generally a large tumor or a locally advanced tumor, TARE is often the preferred line because of the side effects that may be associated with treating large tumors. But if the lung shunt fraction is high in these patients and we cannot proceed with the TARE, in these patients sometimes we proceed with the chemoembolization as the initial proceeding to cut down the the shunts which happen intratumoral. So thereby reduce the lung shunt fraction and reassess this patient again for TARE. It is almost like we are downstaging these patients from a TARE in incompatible cases to TARE. Now coming to the SBRT, combining TACE with SBRT, if there is any recurrence left behind after TACE and the location of the lesion is such that we are not able to proceed with the ablative option, or the patient is not fit to undergo a surgical option, or the patient has developed focal any vascular invasion sort of scenario but still liver limited, then we can combine an SBRT to these patients for a local effect.
So in that context, just quickly, in the want of time, is there a scenario that you will use SBRT first, for example, in a VP3 kind of a thrombus, and then do a TACE because TACE becomes difficult?
Personally, looking at the technicalities involved, we will always prefer to do the TACE first than SBRT, because once the SBRT is delivered, there will be a lot of hyperemia which will preclude proper delivery of our oncological chemoembolic agents, especially if you are trying to combine it with TACE.
Okay. So thank you. We'll invite speaker.
Thank you, sir.
Thank you.
Next session, we'll have a talk by Dr. Sumit Malpure on the role of PRRT in neuroendocrine tumors. Dr. Sumit is a professor and head of the Department of Nuclear Medicine, KMC Manipal.
So this particular talk will be a very brief introduction on when, how to do PRRT and what are the guidelines and evidences for the same. So this overview, first we'll go through the basics, then how we do the procedure and some evidences for the same. First, for neuroendocrine tumors, what do? We do check for somatostatin expression, whether the tumor present in the body is expressing SSTR or no. How do we do that? We do gallium dotanoc PET CT. So this is one imaging in which we will get spatial information whether the primary tumor is expressing SSTR or all the distant metastatic sites are also. So this is the first thing what we check before going ahead with PRRT. Second thing is octreotide withdrawal. The patient usually before coming for PRRT will be on octreotide or long acting. So we will stop that for 1 month, 4 to 6 weeks. And if it's a short acting agent, then for 124 hours. What are the contraindications? First absolute contraindication is pregnancy. We don't use any radionuclide therapy in pregnant females. Relative contraindications are renal failure, because this agent actually is excreted through the kidney and the residence time of these radiopharmaceutical in kidney is significant. So they will have acute kidney injury, and if it is a CKD patient, it's a relative contraindication. We do give renal protection for these patients. So before, on the day of admission only, if we have planned PRRT, we administer gelfusin, that's amino acid infusion, so that these amino acids are taken up by the kidney, the receptors are fulfilled, and when the actual PRRT comes, that radiopharmaceutical is not taken up by the kidneys. It is excreted directly through urine. So there is no residence time in the kidney, minimizing the effect on renal function. How do we administer? So we have 2-3 agents. One is lutetium-177 is what is there in the guidelines. Yttrium was used earlier. Now yttrium is not used because of the renal injury. Lutetium causes significantly less renal toxicity. And the third newest one is actinium-225. This is an alpha emitter. Basic difference between lutetium, which is a beta emitter, and actinium is the killing power. Alpha particle has around 200 to 400 times more killing power than lutetium-177. The dose is also less, as you can see, just 2 to 4 millicurie for actinium, whereas it's 150 to 200 millicurie for lutetium dotatate. How do we place it? We give it in 4 cycles, 8 weeks apart. Before starting the first cycle, we do imaging, that is gallium dotanoc scan. And after 2 cycles, we repeat the scan and serum chromogranin A just to look for response. If the patient is responding, we continue with the next 2 cycles. If the patient is progressing, there is no point in giving PRRT. This is what we check. We do gallium dotanoc and FDG scan. I will come to that later. So in well-differentiated, as you know, observation, somatostatin analogs, that is octreotide, is the first line of management. If the patient is progressing on somatostatin analogs, then PRRT is given. Whereas in grade 2 tumors, you can choose PRRT or PRCRT, that is PRRT plus chemotherapy as the first line. So again, these are the indication, neuroendocrine tumor of any origin. Initially, the paper which was published in NEGM was for midgut tumors, but recent update is any origin, that is it can be a carcinoid, a gastrinoma, insulinoma, etc., etc. If it is grade 1, grade 2, we can go ahead with PRRT. Everything else, this is the first thing what it should satisfy. All the lesions should be somatostatin positive. And metastatic disease not amenable for surgery. Obviously, if it is if we can do metastectomy, if it is a single or oligometastasis in liver, patient can be done surgery along with the primary tumor, go ahead with surgery. Followed, if it is not amenable, then go ahead with PRRT. And progression on somatostatin analogs. Coming to evidences, so this was the first paper which was published in JCO. This is a phase 2 trial where they saw the efficacy and the toxicity of the PRRT. Here, as you can see, survival benefit of 40 to 72 months as compared to the control group. Control group was octreotide. This was done in grade 1 tumors. The second, this is a phase 3 trials which was published in NEJM. As you can see, lutetium dotatate arm as compared to the octreotide arm, there was significant PFS benefit. When they did an overall survey, the interim analysis showed benefit in OS. However, after 10 years after the study, they released the entire data, which showed that even the control group did well. The main reason for this was significant crossover from the control group to the lutetium dotatate group. Again, this is the NCCN guidelines where you can see that PRRT with lutetium dotatate if somatostatin receptor positive, and it should be used as first line even if it is Ki-67 is more than 10%. So this is not just in grade 1 and grade 2 tumors, it is also used in well-differentiated grade 3. So this was a phase 3 study, the NETTER-2 trial. NETTER-1 was in grade 1 and grade 2 mid-gut tumors. This was in all the neuroendocrine tumors of any origin, even in advanced grade 2 and grade 3 diseases, where they saw that lutetium dotatate plus octreotide. This is 30 milligram octreotide, whereas you give 60 milligram. If it is an octreotide alone treatment, it was 60 milligram higher dose. If it is a combination therapy, that's lutetium plus octreotide, it is 30 milligrams. This trial showed that lutetium dotatate should be considered as the first line of treatment and the new standard of care in these population. That is well-differentiated high-grade tumors also. Now, how did we come to this? Now, this is more of clinical data which I will be presenting. When we say that it is a high-grade or poorly differentiated neuroendocrine carcinoma, still in that carcinoma group also, there is well-differentiated and poorly differentiated. Well-differentiated tumors do express somatostatin, and PRRT can be offered in these patients. How do we differentiate between these two? We do dual PET-CT. One is, first we do Dotanoc PET-CT and then FDG. If it is Dotanoc positive and FDG negative, this is the best candidate suitable for PRRT. When do we do FDG? If it is an intermediate grade. You take biopsy, you see that it is an intermediate grade, grade 2, grade 3, or when you do a somatostatin expression, even in grade 1, let's assume you have taken biopsy from a patient, biopsy comes as grade 1, well differentiated, you do a Dotanoc PET-CT, you can see many lesions which are Dotanoc non-avid or mild avidity is seen. In such patients, better do FDG because there might be lesions which are grade 2, grade 3 in the same patient. Or else clinically, you are seeing that the grade 1 NET patient is progressing within 3 to 6 months. You can fairly conclude that patient has mixed tumors in his, and then you can go ahead with FDG PET scan. We do something called as PET-NET score. PET-NET score is basically what is the SSTR positivity and FDG positivity. Based on the scoring, we can treat. Many people don't use this. Why we do this? Because since Dotanoc positivity as well as FDG negativity, these are the patient population in which prognosis is very good. Whereas FDG positive patients and SSTR negative will have significantly poor prognosis. I will show you a few cases. This is a 51-year-old male with pancreatic mass diagnosed as poorly differentiated carcinoma. However, synaptophysin was positive. Treatment, as usual, went ahead with chemotherapy, cisplatin etoposide. However, patient defaulted, and when he came back, he was subjected for Dotonac PET scan. This was in 2016 when, if it was a neuroendocrine tumor, they used to do somatostatin Dotonac scan. Here you can see almost all of the lesions are SSTR positive. However, do we go ahead with PRRT in this case? The answer is you have to do FTG because it was poorly differentiated. And in FTG, we could see that there are multiple lesions which are SSTR mild positive or negative, but FTG positive. These are the patients in which PRRT won't work. So just by doing 2 scans, you will be able to judge which patients will go for chemotherapy and who will go for PRRT. So this is one more case we need to show. So all the lesions are both SSTR positive as well as FTG positive. In such cases, there is a combination therapy called PRCRT. There is PRRT with Captem regimen, which the patients will be, the treatment of the patient will be better. So this is one paper which was published in EJNM, in which they assessed lutetium PRRT plus chemotherapy, that is Captem, in patients with FTG-avid neuroendocrine tumors, where they saw that there was 30% objective response rate and the PFS was almost 48%, as compared, if historical data you can see, it is about 12 to 16 months for such patients. Another patient, a 46-year-old female, presented with multiple liver metastasis, Ki-67 index 25%, neuroendocrine carcinoma category. They did an FTG. How do you know this is an FTG? Just look at the head. If it is bright, then it is an FTG PET scan. You can see most of the lesions are FTG positive. Went ahead with chemotherapy. However, patient progressed within 3 months. Then she complained of frequent bowel movements more than 3 times a day. Chromogranin was high, so which indicated that the patient can have a well-differentiated component to it because there are hormone. She had these symptoms. They did a somatostatin gallium Dotonac PET scan in which all the lesions were SSTR positive. So we started with PRCRT. How is PRCRT given? PRRT on day 1 followed by 14 days of Captem regimen. As you can see, there is near complete response for this patient after this treatment. They have assessed this Captem regimen in most of the in few patients, where they saw that lutetium Captem regimen had significant OS. OS has not reached. Medium PFS was around 42 months. Coming to PRRT versus everolimus, objective response rate was seen in 47% of patients in PRRT group as compared to everolimus, and PFS was better. Most significantly, there are very less side effects with PRRT, apart from AKI, which is seen rarely these days because we use lutetium only. There is only dry mouth as a side effect. It can also be given in neoadjuvant. You have an unresectable pancreatic mass, you give lutetium PRRT in neoadjuvant setting, decrease the size of the mass and then go for surgery. Just to conclude, you have a patient with neuroendocrine tumor. If it is grade 1, somatostatin or Dotonac PET scan. If it is grade 2, grade 3, do FTG also. If it is SSTR positive, FTG negative, go ahead with PRRT. If it is both SSTR and FTG positive, go ahead with PRR-CT, that is along with chemotherapy. And if it is somatostatin negative, directly for chemotherapy. Thank you. Any questions?
Excellent summary. Any questions? Sorry, we don't have time for the questions. Sorry.
Okay. One question we can think. He's already up. We have to have both together, but operated can be for 30 milligrams, not 60. Actually, we started with 60 milligrams, but now we have cut down to 30.
Our next talk will be by Dr. Shailesh Srikhande.
Was a professional reason. We finished one very apt for this lecture. We finished a case after 15 hours of surgery at 2 o'clock today morning, and it just became impossible to manage it. Patient is getting extubated now and fine. Thank you, Dr. Navina and the organizing team for bearing with me. And I apologize for not being there and for you making the exception for me to be able to share my presentation with you. And thank you for this invitation. Are you able to see my presentation now? Thank you, respected chairpersons. And I will try to say what we do as a routine at Tata Hospital and what we have learned over the years when we approach a case of borderline resectable or locally advanced pancreatic cancer, but always trying to see in this difficult group of patients how we can maximize patient outcomes. Now, this is the ground reality of pancreatic surgery. 30 years ago, N0, N1 disease, 26% patients alive at the end of 5 years after surgery. But if you have N0, you have 41%. But mind you, that was a small number of 64 patients when John Cameron published his series of 1,000 Whipples in Annals of Surgery in 2006. We all know that pancreatic cancer is now considered more chemoresponsive than ever before. A decade ago, we never thought that we had any worthwhile chemotherapy, despite all the efforts of SPAC and CONCO and so many other trials. But I think this has been a clear shift where you see that if you operate well and give modified FOLFIRINOX, patients do better than the conventional gemcitabine, which was being given for the last 2 decades. But even in that trial, there are important lessons for us. I know this is a surgical talk, but the surgeon must be fully aware of this when we approach a BRPC or an LAPC. That in the first slide or the left panel, you will see that adjuvant FOLFIRINOX demonstrated a biological effect, indicating that even after upfront resection, there is microscopic disease on which chemotherapy works. So we have clear evidence of pancreas cancer being a systemic cancer, which we have always known. And the right panel, number 2, shows that even after apparently successful surgery, there is an early fall off. See that red circle in survival due to death from disease progression in patients who have been treated with upfront surgery. So R0, good surgery skills, extremely important, but this is what the surgeon must evaluate, especially for BRPC and LAPC. And the other message is that you clearly need to give 6 cycles of chemotherapy. We have had multiple studies where if you give less cycles, patients don't live as long as the landmark PRODIGE trial. So this was adjuvant treatment for pancreatic cancer. And then we have neoadjuvant therapy, which is very important in borderline resectable and locally advanced. And the reason is that if you do upfront surgery, the R1 resection rate is much higher. If you do surgery after neoadjuvant therapy, the R0 resection rate is much higher. And if you have R0 resections, patients tend to live longer. We also have a change in mindset, both in radiology and in the minds of surgeons and not just medical oncologists. And you can see this from one of our earlier studies where we evaluated more than 160 or 181 pancreatic resection specimens. And you see the number of R1 resections, the posterior margin 33%, the SMA margin 33%, the neck margin 20%. At the end, a pancreatic head cancer has got an R1 resection rate of 57%, and even smaller tumors like ampullary have an R1 resection of 7%, though you will feel that they are all R0 on the operation table. So remember chemosensitivity, remember when to use and how to use chemotherapy, and also remember that what you thought formerly was unresectable and locally advanced might well be borderline resectable or resectable. And there are 4 parts to it. One is radiology, one is tumor response and biomarker, and then of course the patient's condition. And of course, we need to change our mindset that it is the same cancer in different locations that needs to be sometimes treated aggressively. So if you want to treat these aggressively, these are 3-4 techniques. This is one of my old slides where you show that you can do an SMA first approach by various approaches. And then you have a situation where you completely mobilize the tumor away from the vein and artery, isolate the artery, and then you are able to go much more medial to the uncinate process and even the mesopancreas, for which you should be comfortable with the various approaches, the SMA first approach. This is the original paper of 2012, but one of our chairpersons, my younger colleague Manish Bhandare, has now also published the 7th one. We have published that in Journal of Gastrointestinal Cancer. I have not cited it here, but I should be doing it. The other thing is the importance of INOU in showing LV1, LV2, and LV3, that the minute you have vein or artery involvement, you are essentially working on one of the 3 black lines, but in BRPC and LAPC, it is LV2 and LV3 that you will be working upon. And the extreme end is doing a subadventitial dissection by leaving a little bit of muscle, not completely going to the elastic lamina. Otherwise, they will all get big pseudoaneurysms or a rupture of the artery. But Yi-Meow tends to go a little bit deeper in the subadventitial plane so that you can avoid an arterial resection, but again make a near impossible locally advanced case into a possible case in this modern era. This is a standard vein resection. Again, one of my old slides where we have done SMA first, got vascular control, just a vein involvement, splenoportal confluence intact, a single running suture of 50, double-ended proline, 17 mm needle, and you are able to do an end-to-end primary anastomosis. There are cases, for example, this case, a lawyer.
What is SLA? The supply is coming from the distal part of the SLB. It is forming a collateral, something like the arteriogram we see on the left, and then filling up the non-obstructed component of the SLB here, and then going into the portal.
So here was a tumor where we did not have a good vein
systemic shunt happened there.
to reconstruct.
Which is one reason why the blood supply is impacted because of this particular.
So you can see that we have a situation where the vein was involved. We did not have a good vein to reconstruct, but we had good collaterals taking the blood back to the liver. And then we put these bulldog clamps above and below the tumor, involving the vein, and lifted off the pancreas from the neck. You can see the splenoportal confluence. And the end result is we could resect it without a reconstruction, and the bowel quality is not affected. So in selected cases, you also have one more option so that you don't label this as locally advanced unresectable. Vein resections carry more operative time, they carry more blood loss, and R0 margins are difficult to achieve. But still, there is no contraindication. Clearly, if you want to keep these cases safe and have good oncologic outcomes, you require a lot of experience in pancreatic surgery. A more simpler case here, but I'll tell you why I'm showing this. A pancreas clinic decision that this is BRPC, a small degree of irregularity, chemotherapy given. You can see the contour has become less, CA19-9 became less, pancreas anastomosis and bile duct anastomosis after resection is fairly simple. You can see here it's the portal vein just at the junction and above the splenoportal confluence where the tumor is now hanging after SMA first and after a triangle clearance. And then this is another view from the side highlighting the triangle clearance and lifting the tumor off. And then we are able to do the transaction lines and again do a type 3 ISGPS anastomosis. We have published our series done by my other colleague, Dr. Vikram Chaudhary, and this is 201 BRPC cases, majority of them neoadjuvant. You get superior overall survival and disease-free survival, provided you resect them after neoadjuvant therapy. We have also done a few arterial resections. We don't do too many, but here in the initial period of 8 years, we have done 63 extended pancreatectomies. And during that time, you will notice only 22 patients got neoadjuvant therapy. This is a splenic artery which is divided, and common hepatic artery is resected, and the splenic artery is swung to join the right and left hepatic artery. There was no portal vein involvement. There was no pancreatic involvement. So this was just a standard Whipple with a hepatic artery resection. Mortality is higher, but you have a 3-year survival of a little over 40%. But you can see that we do standard Whipples 620 and extended Whipple 63 from 2007 to 2015. Now you see this is a case where we have got a neuroendocrine tumor. This is not my brief, but just to explain to you that when you have tumors like these also, you can plan a graft or a shunt, either a mesocaval or put it above. And then in this case, being a neuroendocrine, we have done both a vein resection and an artery resection, and yet done a fair bit of divestment as well for the splenic and the common hepatic artery. So now in period B, that number from 63 has gone to 197. So we clearly do more of these extended pancreatectomies, and we see that there is a trend to improved survival, all for BRPCs and LAPCs. This is another case where you can see first, I will discuss the video. This is a video of Dr. Bhandare himself, where we have done a case of locally advanced, I would say. You can see that the artery is to the right, and he's entering in the divestment plane. This is like the Yi-Meow procedure, where we have published this now in Annals of Surgical Oncology. This tissue is, of course, sent for frozen, but because we have given chemo and radiotherapy, that's the best you can do. The other best thing you can do is to tell the patient we can't do surgery. But here, a number of these patients after these kinds of resection will get a survival advantage. Now in the picture on the left side, you will see the yellow triangle. That's the triangle tissue. We have done a type 1 portal vein resection, lots of clips to hopefully prevent chyle leaks, a Ram's procedure, left renal vein. But we have preserved the left gastric artery and divested the terminal end of the left gastric artery. So you can see how thinned out it has become. And then we have taken a graft from the spleen or the resected specimen and put a splenic artery graft to reperfuse a liver which had got total neoadjuvant therapy. You can see this case of a celiac axis with a tumor involving proximal common hepatic artery, involving the whole of the splenic artery and coming almost to the root of the celiac axis. But at the end, no residual viable tumor, but all margins free, node negative. This lady is doing well for over a year and a half now. So disease is the same, but we are getting better. Is a Appleby procedure worthwhile? You can see that this is one of the largest multicentric studies. Only 5 high-volume centers and 18 low-volume centers from Europe. And you can see that 91 of these cases, 5.5% mortality at 90 days. You have to decide which are the important factors dictating outcome: high volume, low volume, age, sex, ASA, BMI, multivisceral, conventional versus minimal invasive approaches. And the R0 resection rate is 60%. Unfortunately, I see that neoadjuvant therapy is only 69. And this is where surgeons can improve by giving more chemotherapy plus minus radiotherapy pre-operatively. Even the adjuvant treatment rate is 60%. Surgeons should strive for this kind of an operation to have an adjuvant chemotherapy rate of 80% or so, you get 19 months overall survival. So it's a good surgical procedure, but choose your patients, choose your surgeons, and give a minimum of 4 to 6 months of neoadjuvant treatment before you offer them celiac axis resection. Now, this is another case, and this has been done this week. What I wish to show you is that when you give them adequate chemotherapy, we have gone down to resect the celiac axis. We have done a degree of divestment. We have safeguarded the left gastric. We have safeguarded the splenic, but you can see the tumor. And at the end of it, frozen sections further down and complete clearance of the triangle, including the 3 arteries safeguarded. So we have been able to divest and avoid a fairly straightforward celiac axis resection also. So that also depends on how good is the response to biomarkers and to chemotherapy. So I've spoken about this before. Choose the anatomy, make sure that the response to CA19 is good and consistent, and most importantly, select on which patient you should offer such kind of radical surgery. And there would be a number of patients where you should not offer, however skilled you may be, to do these surgeries. So this is our volume every year of pancreatic resections. We have now crossed 2,600. We have a mortality of 3.5%, but that's also because we are having more surgeons, we are doing other procedures, we are doing extended pancreatectomies, we are having less of a selection bias. We have much more referral to do the complicated operations like the one I did yesterday for 15 hours. All these procedures have different learning curves. Don't think that by doing 60 operations or Whipples you are done. It's an ongoing process. I was just discussing with Manish today morning that even yesterday's case is a learning experience for me. Some other day I will share with you how one can last for 15 hours to do an operation. So you have a learning curve for open, lap, and robotic, and you need to standardize it. I end my talk by showing you, is complex life-threatening pancreatic surgeries worth it? You have a ophthalmologist, node positive, running marathons and doing fine. I have their permission. He was my senior and he's practicing in Pune. And this is that same gentleman who came to us from Gurgaon. And
नमस्कार दोस्तों, मेरा नाम संदीप यादव है और मैं गुड़गांव से बिलोंग करता हूँ। 2019 में मुझे पैनक्रियाटिक ट्यूमर हुआ और मैं गुड़गांव के हॉस्पिटल्स में जैसे कि आर्टेमिस और मेडिस्ट्री जैसे बड़े नाम शामिल है, मैंने उनमें दिखाया।
So I think what I'm trying to highlight is that people can come back to a completely normal quality of life, provided you select them, and then you will see that this is gratifying to do as well. Of course, the overall story of pancreatic cancer remains difficult. Ignore this. This is a very good paper for younger members of the audience, but just look at the median survival. Resectable disease, 26 months, borderline resectable and locally advanced, 12 to 19 months. So obviously you need to select, but the ones who respond well, if you do radically well, you are definitely going to give patients to a chance to live long, like I showed you in my previous slide. So I think in 2025, we are operating only 20% of our locally advanced and borderline resectable cases. But in the future, I think we will definitely operate many more just by getting better ourselves as surgeons. We will see an increasing incidence of this group of patients and this cancer. We'll hopefully in the next decade have better chemotherapy than FOLFIRINOX and GEM nab-paclitaxel. And therefore, we should be prepared for more surgery, not less surgery in pancreas cancer. We are going to get new biomarkers because it takes 10 years for a neoplastic cell in the pancreas to develop into distant metastasis. So we will discover some new ways to detect pancreatic cancer earlier than before in the next 10 years. Till then, yes, we do see a 19.9 and some aspects. So I continue to look at this optimistically as we go into the era of tailoring therapy, measuring the response, and understanding the biology of an individual patient of pancreas cancer. Thank you very much for your kind attention.
Professor and Head of Department of Gastroenterology, KMC Mangalore, Dr. Nagarjun Rao, Associate Professor, Department of Surgical Gastroenterology, Father Muller Medical College, Mangalore, Dr. Ashfaq Ahmed Mohammed, Professor and Head of Department of Surgery, KMC Mangalore, Dr. Harish Chandra, Professor and HOD, Department of General Surgery, Yenapai Medical College, Mangalore. For the first talk on MDT HCC management, I would like to invite Dr. Sonal Asthana onto the dais. Dr. Sonal Asthana is a lead consultant, hepatopancreatic biliary and liver transplant surgery, Aster Hospitals, Bangalore. I would also like to invite the panelists for today's first session onto the dais, Dr. Rakesh Pinati, Medical Oncologist, Hyderabad, Dr. Arun Philip, Senior Consultant, Medical and Hemato-Oncology, Cochin, Dr. Soumya Panda, Medical Oncologist, Bhubaneswar, Dr. Manjunath KV, Department of Surgical Oncology, Bangalore, Dr. Santosh Chikkareddy, Surgical Oncologist from Hubli, Dr. Sridhar PS, Radiation Oncologist from Bangalore, Dr. Shirley Lewis, Professor and Head of Radiation Oncology, KMC Manipal, Dr. Harshit Kramadhari, Intervention Radiologist, Manipal, Dr. Mandeep Sagar, Vascular and Neurointervention Radiologist, Mangalore, Dr. Sandeep Satsangi, Senior Consultant Hepatologist from Bangalore. A humble request to the speakers, as we have already fallen behind the schedule, to kindly comply with the time frame allotted.
Okay. Don't worry, you're closer to me. You're closer to the moderator. So, good morning, everybody. Thank you so much to the organizers for this for this honor of conducting this MDT. So there's a recent movie called Mission Impossible by Tom Cruise. So I'm supposed to go through the entire MDT with 10 panelists from 25 minutes to 20 minutes. I think it's going to be a mission worthy of Tom Cruise himself. Okay, thank you so much to our panelists for joining. These are my appointments. So basically, we are talking about an HCC MDT and why it is different from most other tumors. We are dealing with two different problems when it comes to liver. One is obviously we are dealing with a tumor and a damaged liver, which might be a damage because of hepatocellular damage, where people have jaundice, or it could be portal hypertension. And of course, there's a different set of tools that we have, apart from surgical resection. We have non-surgical treatments, liver transplantation, embolization, and systemic therapy. And of course, the last part is most important, availability and access. What is actually available to us to treat these patients? If you look at a very simple algorithm for HCC treatment, you can have a good tumor and a good liver, where the liver quality is good, where we have many treatment options available. And then, of course, in the last, you can have a bad tumor with a bad liver, where there's a cirrhotic tumor with an advanced liver disease. And unfortunately for us, most of the tumors that we see come in this last segment. So what does an expanded MDT for a transplant oncology patient look like? Of course, you're looking at two competing problems, each with a mortality risk. So no single provider can actually have the answer for all these questions. We have to think about the management of the tumor, the management of chronic liver disease, but also define futility, define a time when perhaps all our intervention may not lead to a good outcome. So an expanded MDT, of course, is important because we can consider all these aspects, and more importantly, we can learn from each other when it comes to new research and related fields, because it's very, very hard to keep up with research that is happening in diverse fields which are different in oncology and liver disease. So who would be in an MDT? I think pretty much everybody on the panel right now is what would potentially be on an ideal MDT right now. We have panelists from medical oncology, surgical oncology, radiation oncology, interventional radiology, and Dr. Satsangi is carrying the flag for hepatology. So we do have a complete panel here. With that, we'll go on to our first patient, a 64-year-old man, diabetic, non-alcoholic, had some very vague right hypochondrial pain, The numbers are in front of you. Creatinine is a little bit high. The liver functions are broadly normal. This patient had a grade 3 fatty liver, non-cirrhotic, with an SOL in the right lobe. There was no portal vein thrombosis or no ascites. So we did an MRI, and I'll ask our first panelist, Dr. Harshit, to please go through this MRI.
We can see a tumor in the segment 6. Lesion approximately should be measuring around 3 or 4 centimeter in size, which is arterially enhancing and has washout with the capsule in the delayed phases. Well defined, no portal vein thrombus. Again, we'll have to review the entire MRI to rule out a metastasis or a nodal status, which is not seen here. Then again, it's a localized tumor, sir. This
Sure.
is what I would infer with the provided images.
Sure. So my first question to you is that, is a 4-phase CT or MRI adequate to diagnose in HCC today?
Definitely, sir. Now that we have IVIM and newer sequences with diffusion, better diffusion sequences at 3 Tesla, we're almost switched over to MRI, sir.
Sure.
Where you can see the diffusion images and can look out for a metastasis also.
Sure. And the next question is, if you had the choice of modality, would you prefer a CT scan or an MRI?
I would prefer an MRI, sir. It would detect even a smaller lesions which are not seen on CT with the help of diffusion imaging.
Okay, perfect. So that's one, probably passage number 1. A 4-phase scan is probably adequate to diagnose HCC, especially with lesions that are more than 1 centimeter in size. The arrow here is a sign of a contained rupture in this tumor as well.
Correct.
This tumor had ruptured but had not spread. As doctor has already said, these are the MRI findings. We went ahead and evaluated this patient, did an endoscopy, no varices, essentially non-cirrhotic patient. The markers are raised as well. The AFP and the PIVCA are both elevated. Now this is the question for the floor. How many systems exist for staging HCC? How many people say 4? Can I get a show of hands? Okay. How many people say 10? How many people say more than 10? Okay. Well, you're absolutely right. Actually, there were more than 10 staging systems available even actually 10 years ago when this paper was written. Currently, the number of staging systems is probably more than 15. And most of the time, they are actually looking at various aspects of staging, tumor characteristics, liver disease severity, performance status. But unfortunately, currently, the current markers, most of these systems do not have biomarkers incorporated to a large degree. So the next question again is to Dr. Philip and to Dr. Sandeep Satsangi. Probably the first question is, how would you stage HCC?
Yeah, so in our clinical practice, it is almost exclusively with the BCLC staging system, the Barcelona Clinic liver cancer staging system, because it's quite a simple, very simplified form of staging where you incorporate the patient's performance status and the liver status, and also, of course, the size of the lesions. And you can formulate a plan based on the BCLC staging early on. So that's what we use in clinical practice.
Sure. So, Dr. Sandeep, the Indian Society of Study for the Liver has come out with some very key differences for Barcelona. Would you be able to just highlight these differences?
Yeah, hi. So thanks, Dr. Sunil. So I think the INASL has further simplified the BCLC algorithm and has subdivided each stage into certain other substages, which helps us further enhance the treatment approaches. For example, stage A has a subdivision of A1 and A2. B has a B1, B2, B3. C has C1, C2. And I think these subdivisions make us, if you just see the flowchart over here, it's so easy that under each stage we can select each treatment modality. So it's almost the same, but just more clarity with the INASL.
I think one of the key differences also is that it reflects a little bit more of Eastern philosophy of treatment, which is we are a little bit more aggressive when it comes to surgical resection and transplantation. I'll go into that a little bit more into details as well. Dr. Rakesh, how does the BCLC staging affect the treatment choices?
So basically, I am a medical oncologist. I am really concerned with the treatment of metastatic disease, which starts from basically non-curative intent setups. So it starts from the late intermediate to advanced, and where the lung function is, liver function is preserved. So these days we do have a lot of interventions prior to transplant, prior to TACE, in combination with TACE. So the role of medical oncology is expanding, I would say. As of now, I think we are looking closely at intermediate BCLC B and C. A and D is something that is out of my preview. So I would look to characterize these patients for localized therapies, whether there is advantage of addition of any systemic therapy to ongoing localized therapies, or if the patient is not eligible for transplant, if the patient is having liver function which is preserved, probably to increase the survival by putting the systemic therapy in place.
Sure, thank you. Dr. Sandeep, just coming back to you again regarding the ALB score. This is another score which is quite important because it looks at hepatocellular function as a predominant. Would you be able to speak a little bit about this?
Yeah, so basically the score is given over here. So the lower the score, the better the liver functions basically are. So you have ALBs 1, 2 and 3. So higher the score goes, the poorer the liver functions are. So basically it just says that if your ALB score is better, you can look at more aggressive modalities, like probably think of a resection and stuff like that. And the more you go up, it has a worse prognosis.
Sure. So that's another thing that you could add, Dr. Rakesh, from BCLC as well. So how do you use tumor markers? I mean, this question is for Dr. Panda and for Dr. Sridhar. We'll start with Dr. Panda. What are the tumor markers you normally look for?
So for hepatocellular carcinoma, we usually use alpha-fetoprotein, AFP, and sometimes we use PIVCA. So out of 100 patients of hepatocellular carcinoma, usually in 60% of the patients, the AFP will be raised. And that helps in diagnosing, and that helps in avoiding biopsy many times. So it is mainly based on the radiological and the AFP that we see and conclude. Regarding PIVCA, we can have even in non-malignant conditions, PIVCA can also be raised. Same with the cirrhosis. If cirrhosis is there, then AFP might also be raised. So they are not very specific kind of markers, but they definitely help us to know that whether the tumor is secretory or non-secretory. That helps us in following it up.
So, Dr. Sridhar, any comments?
Same thing. Like if you take as a tumor marker as one of the things, yes, these two are the things what we use.
So in your practice, what is the proportion of non-secretors of AFP?
Less than 5 to 10%.
Okay.
Less than 10%, like single digit.
Sure. I mean, we actually come across quite a number of low secretors of AFP. That is one of the common characteristics of metabolic HCC that we see in India, actually. The next question, of course, is would you biopsy this lesion? And I'll direct this predominantly to my surgical colleagues. Do you need to biopsy a lesion?
Sir, the data has shown that in the absence of pre-existing liver disease like chronic hepatitis B or cirrhosis, the imaging findings may be inaccurate. So I would prefer doing a biopsy in this case, sir.
Sure. Dr. Mandeep?
Sir said already that the non-cirrhotic liver being background, biopsy is the recommendation. So that is.
You're actually right, actually. In the LIRAD does not apply to non-cirrhotic HCCs, so you should actually be biopsying this lesion. But nowadays with the current images advancing modality, you probably don't need to do biopsy for diagnosis. But there's probably another indication for biopsy right now. I'm going to go right into it because of the lack of time. Again, nowadays we are probably swinging the pendulum back towards biopsy for a different reason. One of the first MDTs I ever did with Professor Vijay Kumar about 12 years ago was about HCC, and he was arguing for biopsy, I was arguing against biopsy. But today the pendulum is swung back, and nowadays I recommend biopsy basically for molecular therapies so that we are able to better guide molecular therapies that come, and these are the recommendations from ASLD as well. For LR LIRADs 4 and 5 lesions, and for basically clinical trials, biopsies are coming back into vogue as well. So again, this is basically where we are. The next question basically is to my surgical colleagues, when would you not resect a patient?
There is an extensive extrahepatic disease, sir, metastatic disease and a lymph node metastasis also, and then major major pulmonary vein, portal vein involvement, if there is, then we would like to.
Sure.
And then if there is a future liver remnant which is very, very low, then I would like to.
Sure. So of course there are surgical reasons, there are medical reasons, and there's a medically unfit patient. I must say that with recent advances in anesthesia, this group is actually coming down quite significantly. And how would it decide on liver resection for the transplantation? Dr. Sandeep will be an honorary surgeon here, and Dr. Santosh will be talking, I'd like to get both your opinions.
So I think the most important point would be the underlying liver functions and the portal hypertension. So if I would have a patient who doesn't have a clinically significant portal hypertension, that would be HVPG less than 10, I'm comfortable with a resection. But if you have a bad liver or your HVPG is elevated, then ideal thing would be a transplant.
Sure. So Dr. Ashwin in his earlier talk had spoken a little bit about the Milan criteria. Would you like to speak a little bit about the other criteria that we use?
Yeah, absolutely. So from the criteria point of view, I think most of the centers now follow the UCSF criteria. The UCSF would basically mean that if you have one tumor, but the tumor diameter should be less than 6.5, or you have up till 3 tumor nodules, the largest should be less than 4.5. But the total tumor diameter should be less than 8. Now this is the UCSF, and this is what most of the centers follow. Certain centers are now going a little more aggressive, that any tumor, any number, but the total tumor diameter should be less than 9, but shouldn't have a macrovascular invasion or shouldn't have an extrahepatic spread. But I think most centers are predominantly focused at UCSF or Milan. Right?
Sure. So you already mentioned liver score. This is the score that we normally use in liver disease, looking at the severity of liver disease. So MELD score of 15 basically indicates transplantation. And broadly speaking, to Dr. Sandeep's point, you can transplant patients with larger patients, but of course you have to accept a higher risk of recurrence. And this is the metroteca concept, that whichever score that you use, you can go further, but of course it costs you a little bit more. Again, we can transplant either for tumor reasons or for liver reasons, if the liver is decompensated or if the tumor is beyond a page where you can operate. So Dr. Srikanth, coming back to you on liver resection. So pros and cons of liver resection we've just talked about. What are the surgical considerations that you would use before you resect?
Surgical consideration would be again the same. So the one is whether what is the status of the liver function and the future liver remnant, as well as the presence or absence of portal hypertension.
Sure. So Dr. Santosh, that was confusing. So basically, you're right, because when the liver is damaged, you need a larger FLR, you need more than 40% of tumor. Of course, you need to have an absent portal hypertension. Of course, you have to look at both the size and the quality of the liver that is remaining. So essentially, when we are looking at a resection, we are looking at comorbidity, liver function, portal hypertension, the surgical approach, and the tumor burden. And of course, you're also looking at where you are. Especially in India, not everybody has access to transplantation. So we do resections even for patients who are not recommended in resection in Western literature, such as Child's B cirrhotics, who are well preserved. So these are some of the patients that we resect, and certainly the data that comes out from the eastern part of the world is that Child's B patients carefully selected can do as well after resection as compared to transplant. So resection is an underutilized modality in India. I think we should be doing a lot more resections because not everybody can actually get a transplant. So Dr. Santosh, again, does MIS improve outcomes, minimally invasive surgery?
As such, there have been no randomized trials upfront comparing these two, but most of the retrospective trials and the meta-analysis of these clearly show that MIS has an advantage. So the answer would be yes.
Sure. Thank you. So yeah, the short answer there is yes. So this patient actually had a laparoscopic resection and did quite well. Regarding adjuvant therapy, again, I'll go to Dr. Panda and Dr. Philip. Would you do adjuvant therapy after transplant, after resection?
Yeah, so routinely, on a routine basis, we do not offer adjuvant therapy because the data is still evolving. But having said that, technically, these patients who are high risk, now there is data from the IMBRAVE 50 trial using atezolizumab in patients who are high risk, that is more than 5 centimeters with microvascular invasion or poorly differentiated tumors. They may benefit from adjuvant therapy in the form of a relapse-free survival benefit. The overall survival is yet to be proven. So technically, maybe in view of the RFS benefit, may be a candidate for atezolizumab, but on a routine basis, we have still not started adjuvant therapy.
Sure. So there's some data that if you have microvascular invasion, then maybe lenalidomide would be useful. And like you say, there is some data on atezolizumab as well, but current reports are probably moving away from atezolizumab. I'm going to go through this, not this one. We'll go straight to the next case, the third case, for time. Again, 64-year-old lady, type 2 diabetes, NAFLD, and coarse liver cirrhotic with a tumor. And again, I'm going to ask Dr. Mandeep to quickly look at this scan and tell us what it shows.
Scan shows segment 7 lesion, arterially enhancing, and peripherally, but in the center it's not fully enhancing. I can see a hypodense area in the center. Otherwise, the veins look clear.
So I think I'll just move on to this for interest of time because there is actually a venous invasion here.
Yeah.
It's probably better seen here.
Yeah, now I can see the subsegmental vein involvement thrombus.
Sure. So one common problem that we face is whether this is going to be a bland thrombus or a tumor thrombus. So would our radiology colleagues be able to shed some light on this? How would you decide on whether this is a bland thrombus or a tumor thrombus?
Yeah, on the contrast phases, we can actually differentiate this with bland thrombus versus tumor thrombus.
Sure. Dr. Harshad?
Cases where we cannot give contrast, diffusion would help, sir. The diffusion restricting thrombus would be a tumor thrombus, non-diffusion restricting one is a bland thrombus.
Sure. So you can actually look at diffusion restriction or the contrast testing.
Yes.
And as Dr. Sridhar pointed out, yeah.
PET scan.
Yeah, a PET sometimes is quite useful here because it can light up here. And okay, so Dr. Shirley, the next question is for you. How would you actually grade these grades of portal tumor thrombus?
So depending upon involvement of the first order or the second order extension into the main portal vein, as well as involvement of the contralateral side, you're showing them on the screen already. But also it's important to see if there's involvement of the hepatic vein, extension to IVC, going up to the right atrium. I think there is another staging for that as well. We can classify them to 1 to 3. Presence of thrombus definitely is a poor prognostic sign, right? And then you have to think about what kind of liver-directed therapies and systemic. Of course, systemic therapy, no doubt about that.
Yeah. Now, this is quite important primarily because it also determines the not only the tumor treatment, but also the kind of treatment you can offer. Here, basically, this is a nice paper. I'm just going to go into this here. Is that when you look at the different kinds of treatment available here, depending on the degree of tumor thrombus, you can actually have your sort of prognosis gets much worse from a VP1 to a VP4 tumor. So essentially, when we look at treatment guidelines for advanced, we'll start with sort of medical treatment right now. So can we ask a medical oncologist right now to talk about this, Dr. Philip and Dr. Panda?
Yeah, so when it comes to the advanced hepatocellular carcinoma, so mostly we have got the data for atezolizumab plus bevacizumab, and then we have got the data for recently from the nivolumab plus ipilimumab, and then another is the STRIDE regimen, durvalumab plus tremelimumab. So these are the therapies that are available. So mostly a IO plus a anti-VEGF or a IO plus IO. So these are the therapies that are approved and which has shown survival benefit. Post test also, there is data that IO plus anti-angiogenic might be helpful as well.
Sure. So I'll just ask Dr. Sridhar and Dr. Shirley. So when we talk about SBRT now, are we talking about PVT, RT, or only the whole tumor?
I want to take 30 seconds. So here, like I'll take PVTT is one of the point. I'll go with both the sides, the primary and the PVTT. The liver disease and the PVTT. PVTT is the one what you are established where you are looking for bridging the transplant. That's what we are looking at, that PVTT as a separate, where we are seeing the complete responses. The chances of getting PVTT dissolved and going into transplant is more than 70 to 80%. So that definitely, yes, PVTT wherever it is there, it is not an issue, we can treat only that. So why not liver lesion also? So the size was one of the criteria. As you were the Milan criteria extended the border from 5 centimeter to 10 centimeter now. So the lesion size is not really a problem for me. 10 centimeter lesion is also can be done. I prefer to treat the liver lesion always along with the PVTT. So if the technically and the patient condition is good enough to consider, that's absolutely fine. Even all these patients will also have the PET CT scan and the MRI as a routinely, even for the follow-up. We can give we can see the response also. And then the previous lesion very clearly, if the transplant is not done, surgery is not done, is the patient is not fit enough to be alive, no, we can definitely consider for SBRT for the previous treatment also. Size is not a really important thing for me. Up to 10 centimeter we can do, multiple lesions can be delivered SBRT. Like it's only short duration of treatment. It does not interfere with this, the medical oncology, like intervention in terms of immunotherapy or any of the biological to be considered. Sure. Anything to be added? Yeah.
I think important is that both of these, whether it is as downstaging or it is as a definitive treatment along with systemic, it's backed by randomized trials. So there's a randomized trial for early VP1, VP2, addition of radiation to downstage followed by surgery, in fact improved survival. Similarly, presence of PVTT treated with systemic therapy and SBRT, there is a recent randomized trial from Princess Margaret, that is RTOG 1112, which has shown benefit in addition to sorafenib. One may say that yes, sorafenib is the one which is the used drug and it's not immunotherapy, but one has to also reflect in our own Indian scenario, how many do you end up giving? Majority are actually taking sorafenib or lenvatinib.
Sure. So if I took a poll right now from this one, how many would taste this patient? How many people would taste this patient? It's a VP2 actually. It's going in. Okay, so one for taste. How many would offer tear to this patient? So that's a predictable party lines, yeah? Tear, and nobody else? Tear? And how many would offer SPRT to this patient?
Oh, I'm so happy.
I think
we are always seeing that, okay, nobody is to lift.
So we are progressing. So we are really running short of time. So Dr. Harshit, can you just talk us through how we would select a patient for tear?
Tear again, main indication is portal vein thrombus, sir. And in patients who want radiation segmentectomy, where you can actually, like sometimes where you want the right lobe to get atrophied and you want the FLR to increase on the other side. So it can also help in that. Then again, portal vein thrombosis is the main indication. And a recent study, they said even more than 5 centimeter and above lesions can be teared, provided the finances do allow.
Sure.
Then again, portal vein thrombus, it doesn't decompensate the liver as fast as it is. Regular taste.
So I think the important thing is that current tear as well as current SBRT offers a much higher tumor dose as compared to previous thing. So your previous studies of tear and SBRT are not really comparable to what is being done today. That is that's quite different. Of course, the SIT concept everybody knows. There are radiation labeled, particles which are injected in a 2-stage procedure. They essentially sit inside the tumor and they release the radiation slowly. And then, of course, we have fairly good results. Going from BCLC A to C. SBRT again, Dr. Shirley has discussed some of the data and processes. We had an early Princess Margaret study, and this has been followed up by 1112, which he just talked about. Dr. Shirley, do you want to talk about this as well? In PVT, SBRT? You already talked about this. Okay.
Yeah, I just spoke about it.
And so again, we talked a little bit about SPRT. Now it's not just for PVTT, but it's also for tumor. Right now, of course, there is a lot more data for SBRT as compared to TACE and TARE right now. In this last 1 year, there have been a lot of excellent trials which show that SBRT is coming out to be a comparable thing.
Here I want to concentrate that the percentage of local control is more than 92%. More than 90% is definitely local control.
Sure. So SBRT right now is coming out on its own, and certainly over the last 1 year, we have a lot more data coming out in support of SBRT. So in systemic therapy for advanced SCC, of course, we have to select patients without advanced liver disease or bleeding risks. There are 3 key trials, so I'll just ask our medical oncologist to summarize them one by one. Dr. Philip on IMBRAVE.
Yeah, so the IMBRAVE was the first one which came out with the evidence for immunotherapy and VEGF inhibitor in HCC, and it was a landmark trial in the sense that after a long time, survival benefit was proven with the use. So if you see the overall survival was 19 versus 13 months, it was significantly better. And a good thing was that it included patients with VP4 also, about 15 to 20% patients with VP4, whereas the Himalaya trial using durvalumab had excluded VP4 patients. And one thing I think probably that we should note is that majority of the benefit was derived in patient of a viral cohort. Majority of patients that we see are non-viral, either NASH or alcohol-related cirrhosis, and majority non-viral. So the benefit in non-viral cohort was not much. I mean, the versus the sorafenib, the TKI benefit was not much. So probably in an Indian scenario, we should evolve our own data and see who are these patients who are going to benefit from very costly regimes like this.
I mean, that's an important point because we're using this quite rapidly without any sort of clear ABs currently go to trial. So would you be able to summarize the Himalaya trial for us, Dr. Panda?
Yeah, so mainly now the HCC patients, they are going up to 24 months. So that's
sorry, this is Dr. Rakesh's trial. Sorry about that. Put it up. So,
yeah. Sure. I think the update over survival definitely shows that there is a dual immune checkpoint inhibitors have performed well over the sorafenib. And the interesting point is that even the single agent durvalumab was shown to be non-inferior to that of sorafenib. So for patients who are fit enough to take the drug, and especially if they are having good performance status, the dual immunotherapy is definitely going to work wonders for them. But even patients who are not even willing for that extra toxicities of dual immune checkpoint inhibitors, a single agent durvalumab is also good enough compared to that of the sorafenib. And the median duration of response is significantly better than that of the sorafenib.
Yeah, I think the key bit here was that 20% of people are surviving at 5 years, which is probably the biggest selling point here actually. Dr. Panda?
So this is the Nivo EP data. Right now, FDA has already approved the Nivo EP. One thing we have to be careful with the ipilimumab dose. So ipilimumab dose is here a bit higher, 3 milligram per kilogram, and it is to be given 4 doses. And nivolumab also, it is a 420 milligram in the maintenance part after the initial 4 doses. Somebody who has got varices, probably this is the one which we have to go for. Mainly it depends on the physicians that they have to select out.
1 minute. Okay. No, excellent. I think this trial was published about just on the May 10th, so it's very useful. Okay, I'm just going to wind up right now. There is also some data on complete response to local regional therapy as well. And so this particular patient had tear with 3 cycles of etazobev, had a really good response, tumor cleared, and there was stage migration. So the question now to Dr. Sandeep again, would you consider this patient for transplant now?
Yeah, I think initially was definitely no, but after downstaging and after probably waiting for a period of around 12 weeks, and if there is a good control, the tumor markers don't rise, I think he's a good enough candidate for transplant.
Sure. So absolutely right. So there's a good cohort of patients that can be downstage and then treated very, very dynamically. And rather than follow one standard BCLC, it's important to have a personalized approach where you can actually look at dynamic changes of response and then change your treatment accordingly. So this is our team, and thank you so much for this opportunity.
Thank you, Dr. Sonal Asthana. Thank you, all the panelists.
Any questions at all?
Do you have any Indian figures available for 10-year survival after transplantation for transplant? Any Indian figures?
Indian figures of transplant.
Survival after transplantation.
So there were 2 key papers which I have actually not included here. One was Indian data on etazobev, which was published by Dr. Anand Kulkarni's group from AIG, in which they have actually successfully downstaged patients. They had about 150 patients. Their downstaging rate was about 9.3%. The second was a paper from Medanta that was published by Dr. Soin and Dr. Prehan Bangui, where they have shown Indian data on downstaging and transplantation. And again, this data basically, it was relatively early stage VP1 and VP2, if memory serves me right. And they were able to show 70% 3-year survival. So there is some Indian data, but we do not have, these are basically individual center data. It's not multi-center data.
Thank you, Dr. Sonal Asthana. Thank you, all the panelists.